neurology pathology. All right, this is the last video for neurology pathology that's not dealing with the ear or the eyes. So first we have common cranial nerve lesions. All right, so we already discussed the cranial nerve lesions, but it's important to bring up again. Cranial nerve 5 motor lesion. This is going to have jaw deviation towards the side of the lesion. All right. Once again, whenever we're talking about cranial nerve 5-3, right, that's going to be involving the jaw. Okay, so that's the high yield association that I kind of hammered into you guys a little bit earlier on in this chapter. Cranial nerve 10 lesion, that's going to have the uvula is going to deviate away from the side of the lesion. All right, because you have the palate collapse, the weak side collapses, and the uvula points away from the weak side. Okay, so you have ipsilateral collapse of the palate, and that causes the uvula to deviate contralaterally. All right. Now, cranial nerve 11 lesion, remember, it's about the trapezius and the sternocleidomastoid muscles. So you have weakness turning your head to the contralateral side because the ipsilateral sternocleidomastoid muscle is going to be weakened. So ipsilateral sternocleidomastoid muscle weakened, but that means that you can't turn your head to the contralateral side. And then you have shoulder drop or droop on the side of the lesion because it's ipsilateral effect on the trapezius muscle. Okay. And lastly, you have the cranial nerve 12 lesion, all right? And this is going to be tongue deviating towards the side of the lesion, okay? So you lick your wounds is how people remember it, all right? Now, for probably the most important lesion, we have this thing known as Bell's palsy, which is the facial nerve lesion, okay? So cranial nerve 7. Cranial nerve 7 lesion leads to Bell's palsy, which is essentially just the loss of motor function of one portion of your face, okay? Now, what's going to happen is that it usually follows or develops after HSV reactivation or some type of stress factor, okay? But another thing that they like to ask about is a patient that undergoes parotid gland tumor resection or parotid gland, if they have like a parotid gland tumor, or if they have some type of surgery involving the parotid glands. Remember that facial nerve courses near the parotid glands and it can compress the cranial nerve 7 and cause Bell's palsy. There's also a lot of other things like Lyme disease that can lead to it, which is very, very high yield, okay? Now, there's two separate things. This is why it's important to know. Upper motor neuron lesions of the facial nerve versus lower motor neuron lesions of the facial nerve. Very straightforward. I'm going to make it as simple as possible. Whenever you have an upper motor neuron lesion of the facial nerve, you're going to see an issue with lower quadrant deficit, okay? So the patient's still going to be able to wrinkle their eyebrows or wrinkle their forehead, okay? They're still going to be able to raise their eyebrows. They're still able to open their eyes fully, but they have loss of the lower quadrant where they will have they don't have kind of the angle present between their nasolabial fold, okay? So they'll say like the nasolabial fold is atrophied, all right? But they still have the ability to move their eyebrows, all right? So that tells me it's an upper motor neuron lesion or deficit. Now, for lower motor neuron lesion or deficit, it's going to present with a upper and lower muscle facial expression weakness, okay, or paralysis. So the patient's going to present with essentially half of the face knocked out. All right. And so what you're going to see is not only the nasolabial fold is going to be affected, but you also are going to have incomplete eye closure. So the patient can have like decreased tear production in the ipsilateral eye or the affected eye because they can't really close that eye very well. You have dry eye-ness. You have or dry eyes. You also have hyperacusis, right? We already discussed that the facial nerve is going to help us with the stapedius, right, muscle. And without the facial nerve, we can't pull it off, so we have hyperacusis, which is heard. We have loss of taste sensation to the anterior tongue, because remember, spell taste instead of the T's, but 7s. So you know that whenever someone has a lower motor neuron deficit, they knock out that tongue lesion. So they have an abnormality in tasting on their anterior tongue, okay? Overall, what you need to know is whether the forehead is involved or not involved, the forehead and the eye. If the forehead and the eye are involved, then you know it's a lower motor neuron lesion of the facial nerve. And they're going to present with dry eyes and incomplete eye closure with decreased tear production. If you have upper motor neuron lesion, it's not going to be involved. The forehead and the eye will not be involved. And it's only going to be affecting the lower quadrant, specifically that like nasolabial fold is something they'll talk about. Okay? So both affect the nasolabial fold, but only one will also affect the forehead and the eye, and that's the lower motor neuron lesion. All right? I want to make that as clear as day. Hopefully you understand that, and that's Bell's palsy.